it is.
Mike.
I got you.
All right, well, good morning, everybody.
Good morning.
God is good.
All the time.
All the time.
God is good.
Amen. So when we're in a church, we have to do church kind of stuff. Even though this is a medical profession, presentation, we're still good. Most of us, I'm sure, all of us are good Catholics here. So we always like to make sure that we keep that in mind, because we are in a wonderful Catholic institution on the Island of Africa, and we're very appreciative of our speaker this morning. So I'm going to formally introduce our speaker. So I'm sure most of you have seen this gentleman around the church playing his wind instrument, which is kind of a tie into the fact that he's going to be talking about immunology today and asthma. So this is Dr. James Hunter. And again, when he's not playing the clarinet behind our wonderful choir, this gentleman works currently for the Associated Allergy Asthma Specialist, where he's been employed since 2001. But I'm going to go back a little further before he got to his current position. Dr. Hunter is a graduate of Loyola University, where he graduated in 1976 and has a degree, a bachelor's degree in biology. After graduating from Loyola, he attended the University of Illinois College of Medicine, where he graduated in 1976. A fellow graduate of the university, 1980. And as a fellow graduate of the institution in College of Dentistry, I have to say, that makes it very extremely qualified. After completing medical school, he did his he did a residency in pediatrics also at the University of Illinois, and he also has completed a fellowship in allergy and immunology. Dr. Hunter also is double board certified, both from the Academy of Pediatrics and the American Academy of Allergy and Immunology. And being double boarded is actually a big deal, because getting a single board is very difficult, and getting two boards is even more difficult. Again, when he started his career at the United States Institute of Allergy and Immunology at Grant Hospital, where he worked there from 1987 to 1992. After that, he worked at Rush University from 1992 to 2001. And as I mentioned, he currently works at the Associated Allergy and Asthma Specialist, where he's been there since August of 2001. With that, Dr. Hunter.
Okay. Comment is the University of Illinois School of Dentistry treated them like they treated us.
They did.
We had these exams, and they treated us like children. But they knew if you did all the stuff that you were gonna do, that you're supposed to do, you were gonna graduate. And they had, it was really for one of our exams, that they kept changing stuff. And it's like if you pass the test, it's like before you graduate, so you're gonna pass board part 3, they actually do that. And if the students wanted to change curriculums, they changed curriculum. And anything they did, it's like, you're going to graduate, so they don't care. And they were right. And one of the things is that when I was this Max Sanitary that was at Grant Hospital was also affiliated with Rush at the same time. And one of the times when these hospitals were doing things, and they decided they wanted to close our program, even though they made money for the hospital, but they couldn't understand why an outpatient department would be in a hospital. And so they tell people, they fired us. And people said, you didn't get fired. I said, I'm sorry. Our last day was on Friday. Our jobs were gone there. Granted that the next Monday we were at Rush. And nothing ever changed, but it's like they fired the whole department. So, we're going to have some questions. True or false? Some dog breeds, such as Chihuahuas, are better for people with asthma and allergies. True or false?
True.
It's false. There is no such thing as a hypoallergenic dog. I don't know what they like. Children outgrow asthma. True or false?
True.
False. False. This is a chronic disease, and there are times that it's worse than it in others, but it's there all the time.
Doctors tell you they can have trouble. They have less.
Yeah, I know, but they don't listen to what we tell.
That's true.
Moving to the southwestern states for pure asthma and allergies.
True.
False. One of the things that can happen is that because the allergens up there are different than here, is that, yeah, you can move there, and then for a little while you're going to be better, but you can develop allergies to the stuff that's there. And then a lot of the people from the Midwest like our Midwestern plants, and they bring them with them, and they water them, and so they still pollinate out there, so you still have that. And actually, there's a whole list of these that are on there that's in the handout for you to read later. So, when I have done these talks, and this slide was from I was a fellow, and one of the things is like when you're talking about science, and it's like this animals, you think it's biology, and it's all these chemicals and stuff, it's chemistry, and when it's incomprehensible, it's immunology. And this is not really the truth, it's just so much of it in such detail, and then people kind of look at it and say, yeah, they don't want to do that. And so, and one of the things that has happened is that as animals have become more and more complex, you know, those organisms like viruses and bacteria still want to attack. And so we have developed
You're on that side.
I know. You should come over on this side.
You want your audience in one of those.
No. I've been trying. So, but one of the things is that the animals have developed this immune system to help protect you against these microorganisms. And really, as we have gone on, as the animals have become more complex, our immune system has become more complex. And as we come, we'll talk about our adaptive immune system. The microorganisms have been doing stuff to counteract that one. And basically, your immunity, we actually have specific and non-specific components. And the non-specific things are what we call innate immunity. And it's stuff that it's there, and you're waiting for stuff to infect you, foreign particles that come and get you, and it doesn't matter what it is. We have cells that are going to attack that. And I think that I missed a slide. And so, in our adaptive immunity, this is an old way, 40 years ago is how we got taught. They called it this general Coombs way they did identify. And we had what they call a type 1 response. And that's one with this IgE antibody, which gives you an immediate reaction. You get exposed to something, and it's like you're going to have something in about a minute. And that actually is where allergy is in this. And then they had this type 2 response, which is, and when they were doing this, it was like your IgG antibodies, and this was the response that had you get immunity to infections. And then you had this type 3, which was the same antibody, but this is where the antibodies are binding to your cells in your system. And so they give you autoimmunity. And the type 4 was actually a cellular response. And that's like when people have allergy to nickel, they get that. And all of this is not that simple, because even with your type 1 response, you eventually get a cellular response. And so this is one for like in your type 1 response, you'll get intestinal systems. And one of the things is type 1, your IgE system. The purpose of this antibody is to actually protect you against parasite infections. And it's and then I wish we could slide, but it's like basically this antibody is there, and out of all of these, it's in the smallest quantity of any of the other ones. And when you get these reactions, you get you know about allergic rhinitis, you get asthma. You also get anaphylaxis, which is a generalized reaction that you get. And the most common thing that people know about is like the peanut allergy. And other food allergies, they'll give you anaphylaxis. And the same thing will happen with the insect stings, with stinging insects. If you are allergic to the venom, you get anaphylaxis. Basically, it's a generalized allergy reaction.
Yes.
And when you start out, when people get exposed to stuff, one, you actually have this big feeling of impending doom. Because, and I know I've had this, and when this reaction starts, you know something bad is going on. And it's because it starts, when you have these allergies, it starts releasing these mediators. And you will get hives.
Yes.
And you will get fluid in your lungs. You like the muscles in your lungs to close down. And sometimes you get throat swells. And it also affects your blood vessels. It opens them up real widely. And when that happens, your blood pressure drops. And it's like, you can't breathe. You know that, and it's like, and that's why you actually can die. And when you're having it, the treatment that we actually give is epinephrine. And epinephrine is really there it helps to close down some of the vessels and maintain your blood pressure. And it should open up your lungs so you can breathe better. But the epinephrine is just blocking those symptoms. And because these reactions will stop, it takes for most people about 40 minutes and it'll stop. But if you have not intervened, you might not be there for 40 minutes.
That's why I was asking Dr. Just like when you see somebody get a bee sting or something like that, is anything you can do, you know?
If they are allergic, you need an epinephrine. And ideally, they all have epinephrine. And so this is just telling you the type 2, and this antibodies get attacked. They put things up other organisms, and when you get this with these antibodies, you can get when you have drug reactions, you actually have a lot of these molecules bind onto like albumin in your system, and the drug on the albumin is what causes the reaction. But when you do that, you react that, and you get inflammation, and these complexes get caught up in your blood vessels, and so they get, you'll get rashes from that. Graves' disease is one of the thyroid diseases, and you make antibodies against thyroid-stimulating hormone. There's another one called myasthenia gravis, which is a muscle neurological disease where the receptor in the nerve for acetylcholine gets damaged, because that's how you maintain your muscle strength. And if that receptor is gone, you get muscle weakness. And this is just the cellular immunity. And one of the things, when they're calling this type 4, but one of the things is like, you have on there that these cells, your actual T cells are what actually kills viruses when you have viral infections. And what does happen is that after these viruses get inside the cells, they have protein that's actually expressed on top of the cell membrane, and your T cells recognize that as a dysfunction, and these T cells come and kill the infected cells, and that's how you get rid of the virus. But as the process of them killing it and doing all this, this is also why you get sick. And this is one, I forgot to look this up, but there's another one of these that there's stuff, some compounds that are getting inside your body. They can't really get rid of it, so the neutrophils that are in there go in and phagocytize stuff and go.
Question, so the type 4 reaction is how it works?
Is what again?
Type 4 reaction is the one that is responsible for getting sick with COVID because it's related to the virus. Or is that?
That's part of it, but it's more than that with COVID, because that virus does that, so you have to respond to that. Then it triggers inflammation in other areas, and because this is the angiotensin receptor that it's binding to, that it's everywhere, and probably with that you're getting an immune response to that, which is causing you inflammation in those areas. And when and then these people who had the cytokine storms that they called it. One of the things that our allergy meeting a couple of years ago, actually last year, they were doing a session on these healthy people that died from COVID. And it's like they were perfectly healthy, they got COVID and they died. And these people were deficient in one of the interferons. And interferons help to neutralize viruses. It's one of the early things that come to help to neutralize these viruses. And so they were deficient in there. And it ended up, the other part of your immune system is going through this stuff is overwhelming. And frequently with these infections, people die from the immune response that is so intense to try and get rid of this.
Isn't the T cell count of the nature of disease?
And so these are the cells basically that are in your immune system. We have one set of cells that are called granulated, and you have neutrophils, eosinophils, basophils, and actually mast cells. And they're called this based on the staining that they have. And see, this one is a neutrophil. It also has a name that we call polymorph. Oh, I can't do these words. It's a it's polymorphs is what they are, because they're nuclei. It's like it's lobed over here. It's actually one nucleus, but it's actually lobed, and that's why they call them that. And they stain these with basic stains and acid stain, and the neutrophils don't stain with either one of them, so they're neutral. So that's why they call them neutrophils. This one is a basophil, and this is actually the stain that's on there is it's an acid. The secretions that are in there are acid. So this is a basic stain that they're having. So it stains purple, and that's why they call them a basophil. There's another cell in here that's here, that this one is a mast cell, and the mast cells are out in your system, and they're around blood vessels, and they also have, basically these two cells have the same granules that are in them. And basophils circulate through your blood all the time, and the mast cells are out there, and they actually do the same thing. And this one is an eosinophil, and compounds in there are basic, and it's an acid stain. And really, and eosin is an acid, it's acid, and that's why they call them these things, because of this.
So with the eosinophils, when you have an infection somewhere in the body, are those the ones that increase? Is it eosinophils?
It's the neutrophils.
It's the neutrophils.
It's the neutrophils. And so when you said that, unless you were deficient in neutrophils,
Yeah.
eosinophils will start acting like neutrophils.
Okay.
And then we have these other ones that are mononuclear cells, which are lymphocytes, your monocytes. And your monocytes, macrophages, and dendritic cells are actually the same cell. And all of these come from the bone marrow. And your macrophages and monocytes, they actually just circulate all through your system, and they're just looking for stuff that's not supposed to be there, and it'll attack it. And they're part of this innate immunity, and they do that. Anything that's not there, and foreign bodies will do that, because if you get a splinter, if you don't take it out, eventually you're going to get inflammation. It's body trying to get rid of it. And the dendritic cells are basically these cells, but they actually have tentacles that are around all everywhere, and they get up into the cells, and they're in the epithelium and areas, and it's just thinking they're just sticking stuff out there. And this one is a monocyte, and this one is a neutrophil. And I'm looking at these, and I remember 40 years ago outside, I knew all of these cells and what they looked like. But I know when I was getting pictures, they were labeled, and I'm trying to remember all the stuff you remember how they looked. And so, the lymphocyte, and technically, this is all I'm ever interested in, are the lymphocytes. And this is one that, and I'm not going to give you a test on that, so you don't have to learn this. But there's this thing is where you have these naive T cells, and when they get exposed to actually more than that, the monocytes of these cells actually are what we call antigen presenting cells. And so they'll come up and they'll find a bacteria or something, and they'll express some of the protein on their surface. There is a receptor for them with the T cell, and when they present this antigen to the T cell, it's what starts the immune response. And so you have one that you see on here that is this naive T cell that hasn't been exposed. After they get exposed, then it becomes primed, and it starts doing all of these things. And if you hear, like in this area over here, is a response that we actually start calling a Th1 response. And this is where you release gamma interferon. It releases interleukin 12. And that stimulates, and you eventually make more of these mediators that they start affecting your B cells. And then you have over here where it's like when you have an allergy response, it are these, and you have these when you're having infections. And your CD8 cells are those are the cells that help to kill out viruses. They are the suppressive cells. So you have these cells that suppress, and they are releasing. It's like they release alpha and gamma interferon, and these cells also release tumor necrosis factor. And you have these killer T cells. You actually have T cells that go around, and if you have a cell that has mutated and it's a cancer cell, your T cells will go and kill it. And when people have cancer, that surveillance has actually become effective, and that's why cancer will grow.
Say that again.
That's why it will grow?
If your T cell surveillance has become defective, that's why you actually can get a cancer, because you get cancer cells all the time when cells mutate, and your T cells just go and kill them.
Okay, so that's cellular communication.
we call it's cellular trafficking. It's
Okay.
like they because they all talk to each other. They
They
send all,
do.
they send all these signals.
So it's like ADT, the ADT security system for your body.
And then when it breaks down, you get invaded.
Yes.
Batteries up.
And so, and so your T cell controls everything, because after it activates and it's starting an immune response, because it's like, you know, like these viruses, this is what's killing. But eventually you're gonna make antibodies, and so it starts sending signals. And so you have a naive B cell, and it will go and it will start multiplying and then start making antibodies. And the ones that you see on here, they're just saying you have an IgM, so it's on the cell antibody, that's so you can identify it. You have IgG, and then you have IgE, you have IgA, and so they will do all of this and grow. But as they're doing this, you also have some of these cells that go and become memory cells, and so they just kind of sit in there. If you get something else again, it's like you're going to make a response. And these cells actually just circulate all the time. They don't just sit in one place. They just go around and they just go around, and they're looking for stuff. And the antibodies from the lymphocytes, you have IgA, and this is, you can see this is the concentration, basically normal. IgG, that this is the normal. You have IgM, and then you have IgE. And if you look at this, you see how those, they're showing these in milligrams per deciliter. Your Ig is in international units. And one international unit is 2.5 nanograms. 1,000 nanograms makes a microgram. And 1,000 micrograms makes a milligram. That tells you how little of this is circulating. And if you think about the stuff that it does, you don't want a lot of this around. And so this is just a cartoon of, this is the IgM antibody. And this is the oldest one that we've ever made, because the most primitive fish actually make this, and that's the only antibody that they make. These are, you know, like the all the eels and things. It's like this is the only thing that they make. And when you and what's interesting is like we have developed these other things. When you have an immune response, this is the first antibody that you make for every single immune response. This is the first one that you make. And this is, because this is easier, this is showing you the IgG, it's the most common one, and it neutralizes for your bacteria and your viruses, and it binds to a lot of stuff. But there's a part on this that, when we talk about them, it's this part of what they call the heavy chain is why we actually name these. And I think Lauren said, what do these names mean? And it's like, oh, because it's immunoglobulin alpha, it's IgA. Immunoglobulin gamma is IgG. Immunoglobulin mu is IgM. And immunoglobulin epsilon is IgE. And so sometimes when you're reading, they'll talk about this stuff, and they'll tell the Greek letters. But you have this part up here is the antibody binding site, and this is, and these change. This is the stuff that happens in change when you're responding to an infection. And your IgA, but basically they look the same, but sometimes it binds into two pieces. And IgA actually is out in your secretions. It's in your intestinal tract. It actually gets into your lungs. And it's to actually stop this, because, you know, that's protecting you from stuff invading you. So that's where that is.
We talked about the immune system.
Because we're getting ready to go to this one. This is the one we do all the time.
And IgE's real purpose is to protect you against these parasite infections. And so, if you have an intestinal parasite, you'll make antibodies and you'll generate this response. And when it releases these mediators, it's like it gives you vomiting and diarrhea to get this out of your system.
Oh, okay.
If it's in your lungs, it's doing this to get you to cough it out.
Yes.
And if you have stuff in your skin, the stuff is making you itch to get rid of. That's its real purpose. Its real purpose isn't this, even though that's what keeps us in business.
Doctor.
Us.
Oh, the body.
Allergies.
Allergists.
We're allergists. It's like
Allergists.
That's what keeps us in
Allergists.
business. So one of the things is like we have this concept called atopy, and it's the genetic tendency to develop these allergic diseases that, allergic rhinitis, asthma, and atopic dermatitis. And it's actually the tendency to do that is actually inherited. So when you do this, it runs in families. And it has been that when we started out, it was about 20% of the population was atopic. And it's somewhere around 30 to 40% that's atopic now. And we sit up sometimes and ask, we used to not see this much stuff. What has changed from when we started fellowship till now? And it's all kinds of stuff has changed. We eat different food, and we eat a lot of what I like to call fake food. And it's just a lot of stuff. And the environment is different, and it actually has probably increased this.
Is it worse for black people?
They are.
So what about some of the medications that we take, that we get side effects from?
That's another.
Oh,
That's another. This is just genetic stuff.
okay,
So atopic, so when you're atopic, what does that mean?
That means you get these diseases. That's all that.
So it means your body doesn't recognize?
Oh, it is actually, basically, what it's doing is recognizing stuff it don't need to be recognized. It's like
So it's like it's hyped up, so everything.
it is. It is hyped up.
So everything it sees, like anything it sees, it's like, oh my God.
And that's why we have people who have, they keep saying, their immune system is down, they're having all these allergies. And no, it's not. It's turned up. It's turned up.
okay.
It's all your systems.
So, yeah.
But statistically, it is worse for black people? Or do you think so?
Yeah, it is. And there's various reasons why that is. And it's like, and some of it, it's because we're supposed to be in Africa living in the equator.
Wow.
Well, it's because in one of my textbooks, they were talking about asthma, and they said it's a disease of industrialized society.
Okay.
And it is. And in terms of getting worse, we have for allergy what we call one of the is like we call this hygiene hypothesis. And basically we're too clean. And just because I showed you that you have this one that we call this TH1 system, this TH2 system, well, that's supposed to develop balanced over time. And we have now that we don't have nearly as much germs in our house, and we don't get infectious diseases because all these vaccines that you're doing keep you from getting these infectious diseases. When you do these vaccines, you will make an immune response that will protect you from these infections. But the immune response, the way it operates, is not quite the same as it is if you actually have a natural infection. So it does work so you don't get another, but you actually don't get the same that you would if it was a real infection. And all of this, and really how they studied this was that in Europe, they were looking at people who had allergy in the farms and the ones who were in the cities, and the people out in Europe have their barns attached to their houses. Unlike us, where our barns are off someplace else where they belong.
So
But
is that why they say the children should be around dogs?
Well, it's gonna be basically the same thing, because when they're looking at, and they said that when they had that, they had more, the people who lived there had less allergy. And then they're looking at the people who worked in the barns versus the ones that stayed in the house had even less allergy. And then they went on to study of the people who drank raw milk. And you ever had raw milk?
I have.
I had. I
there's
can't
no
stand
phone.
it.
Okay, I can't
stand it. But what's common about all that is like they were exposed to all these extra germs that they were, because it's like these endotoxins that the bacteria releases, like was helping to develop their immune system. And she was saying also about exposing these kids to dogs. Because there was a study one of the groups were doing, and they were looking at the effect of pets that they had in the homes. And their hypothesis was that the more pets you had in the house, the worse your allergies were going to be. And that's not what happened. And as they studied it, you had to expose these kids. I'm not really ignoring. You had to expose these kids to more than one pet before they were a year old. And that actually would affect their allergies weren't as bad. And the only thing about that is like when you're doing this, it's like they have more germs. It's more germs, and so they got more endotoxins, and so their immune system developed normal. And then recently, someone did a study. They were looking at people who lived in houses where they used their dishwashers versus the people who washed their dishes by hand. Well, there was more allergy in the houses that people use their dishwashers. And that's also because, you know, when you're washing your dishes, you clean them and you get them clean enough. They're not sanitized. But they're clean enough, and it's like, you can do that, and it's the same thing. You're stimulating this other part of your immune system. And so, what happens when you have made this IgE antibody, I'm talking about your mast cells that are they're all in your skin, they're around your blood vessels, and you have your basophils that are circulating in your system. This IgE, there are receptors for your IgE on these mast cells, and there's actually about 10,000 receptors on the cells for these antibodies. And to actually have an allergy reaction, you have to have two of these bind to the antigen at the same time. So they have to bind to the same one at the same time. And what that does is like, it actually causes an electrical stimulus to go through the antibody that then affects the receptor, and it causes you to release histamine. And you release histamine and stuff that's like histamine. And so what you get when that happens, you'll get hives, you can get bronchospasm, you can get sneezing, you can get there. And depending on how much it is, you might get anaphylaxis. One of the things that happens with histamine is like it opens up your blood vessels. It makes your blood vessels leaky. And what that allows you to have happen is that you have, like if this is an infection, you get more cells that'll get there to help get rid of this. And unfortunately, if it's in your lungs, it gives you more and more and more asthma. And the other thing that gets released from these is where it attracts the eosinophils. Yeah. And the eosinophils come there, and eosinophils, that stuff that I said, that's its basic proteins, one of them is called major basic protein. And when they secrete it, it will kill parasites. And there's another one they call eosinophilic cationic protein. It kills parasites. Those same compounds, when it's in your lungs and in your nose, damages your epithelium and then makes you worse. I think this slide says the most common diseases that show up in a primary care office is allergic rhinitis, food allergy, drug allergy, and then it's allergic asthma, and then it's atopic dermatitis and contact dermatitis. This is from a slide set from the academy about some other talk, but this is what our primary care people, this is what they see all the time. So, is this what you really came for?
Kind of.
But one of the things, it's like asthma is actually a chronic inflammatory disease of the airways, and it's not bronchospasm, of which how we were actually taught. It's like your airways close down. That's how we were taught. But your airways are really inflamed, and you get this inflammation that you actually get is from these allergy responses and what does it. And this is just looking at this is what the inside of your airway looks like when you're normal. You see how it's nice and open and clear, so air can go through there real nice. Well, this is an asthmatic lung, and I'm presuming this is someone that has had asthma from a longer period of time, and it's not a mild asthma, and it's more moderate. And one of the things that happens is that in here, you get the cells that are lining your airways. The epithelium sometimes will proliferate. You have more mucuses in there. But the other is like when it's long-standing, you actually get more of the muscle cells that are on your lungs actually thicken. And some people it actually scars. And so after a long period of time, they won't get better because it's scarred in there. And we actually call this remodeling of the airways. And this does not happen to every asthmatic. It happens to some, but it doesn't happen to all of them.
Those with autoimmune diseases too. It doesn't happen.
That causes another problem.
Okay.
But that's what happens. But this is what happens, and that's why. These cells up here are basically just normal epithelium, and you can see how it's nice and connected and all there. This is one that has actually been damaged. There are down in here, some of these black spots are more other cells that are in there, but you can see how this is not intact. And when your epithelium is not intact, it's easier for other stuff to bother you. It's easier for cigarette smoke to bother you. And asthmatics have, fumes and stuff, and they'll do that, and the nerve endings that are in there will stimulate a response, because one of the things, function of your nose and your lung and the upper airways of your lungs is to protect the alveoli that are out down there where you actually have gas exchange. And so anything that's possibly going to damage them, you will do stuff to close it down. And so, but when you have this, it's easier for all this stuff to bother you. The other thing that happens when you have intact epithelium, it's harder to catch viral infections. And so when it's intact, it's harder to catch infections. And so patients that have all these allergies that have this, and they say their immune system is down, it's because their epithelium is broken down and you can catch stuff. And when you treat them, when you start treating with some of these medications, it's like you actually can get people to heal up. And with some of our real expensive new stuff that we're giving people, we're wondering if we can actually get them to go into remission. And so when we have people coming in, you start asking questions, and it's like, when did it start? What time of the year are you worse? What medications have you taken for? Then you want to know, did they work? And you want to know if they're getting worse or they're getting better. And this is part of where we do this for allergic rhinitis. We ask some of the same stuff. And one of the things, and these are questions I ask asthmatics at every visit, and you ask at the beginning. You want to know if they have shortness of breath or coughing with exercise. Sometimes people tell us they don't exercise. Then you have to ask them another question. Why don't you exercise? And you'll have people that, if I exercise, I get short of breath. And that's why they don't do it. One of the things that we ask about nighttime coughing, and
So what's the difference between shortness of breath or coughing prevention?
these are just symptoms that they get.
Oh. One thing.
Because the mildest thing that you get if you exercise is coughing.
Oh.
And after, when it gets worse, you're going to get short of breath. Another thing that we ask about is coughing at night. And this is one I said, do you cough at night? And they'll say yes. And then you say, how much? And frequently, it's not that much. And you have to keep asking. And really, because sometimes they're thinking 1 or 2 times a week. Coughing 2 times a month is telling you have a persistent problem. And some of them, they cough every night. They don't think anything about it. And one of the things is like, do you wake up at night short of breath? And anytime you have someone that wakes up at night short of breath, they really aren't controlled. And it's like one time a month is too much. And one of the things we also ask is, how often do you need your rescue inhaler? You don't want them used. They should not need it more than twice a week. And if they are, it's something you need to change therapy. But sometimes you ask people, how often do you use your albuterol? And they say, when I need it. So you ask again, how often do you need it? When I need it. And it's like, so how much is when I need it? And we've had to go on and you start asking, how often do you have to get it refilled? Because if someone has to refill it every month, they're using their inhaler every single day. If it only lasts them 2 weeks, they're using their inhaler at least 4 times a day, every single day, and then it's gone in 2 weeks. And so you have to ask about that. Then sometimes they still aren't giving us good answers. And I've actually asked people, where is your inhaler when you go to bed? And when someone says it's in the bed with them, it's telling you how bad they are. So if they have an episode at night, they don't have enough. They can't get up to go get their inhaler. And the same thing, when people have been really sick and they come up and tell you, oh, I went out to work and I left my albuterol at home and I was okay. And it's like, and it's telling you they have gotten a lot better, because these people who aren't, it's like, they'll be halfway to work. I left my albuterol, they'll go back and get it.
Cigarettes.
That's another. It's less of that than it used to be.
Okay, so I have a question. I noticed that since I had sarcoidosis, that I still have the expiratory wheezes, almost musical wheezes when I wake up in the morning. I can hear them. Is that normal? Is that something?
For sarcoidosis. But basically, you get these granuloma in your lungs that
That's
are
what-
around the airways.
Yes, okay.
And basically, the airways are smaller.
Okay.
And so when the air is going through there, it vibrates and so it whistles.
Yeah.
And that's really why people wheeze. The same thing, the airways are closed and the air is vibrating as it goes through. And unfortunately, prednisone may take care of that, but
18 months.
our inhalers usually don't. And the question is, we also ask, have you ever used steroids?
Yeah, it's only for 18.
And we really don't like you having to use steroids once a year. But we have people that they're every 3 months, and sometimes they come in and you're going through and you're listening, and it's like, that was on steroids, and then because basically the effect from them wears off in about 3 weeks, and you'll see that they get into this cycle and they get into the cycle, and sometimes you're looking, they've never been out of control, and sometimes all they need is to get on something to get them out of there. And so we'll ask about triggers. Go ahead.
So question two, I wanted to appreciate back on there, are those the people who are on steroid inhalers, combination or single steroid inhalers, are they still breaking through too? Or?
They can.
Okay.
And if they are, you start saying, why are they breaking through?
So the ones you say who are coming back every 3 weeks, who are, you're saying that are not well controlled, there's a likelihood they're not on a steroid.
Most of the time, they actually aren't on something.
They're
That's
not.
usually what happens, they aren't on something.
They are not on something, okay.
And so when you're doing this, you're asking people, when does it trigger? Because you're gonna ask about seasonal symptoms, and then you need to ask about their animals. And, you know, for most people, cats and dogs are the major ones. But hamsters would do this. Guinea pigs cause more allergens than hamsters do. Horses are really, really bad. And you'll see this because there are people who have horse allergy will almost get anaphylaxis when they go horseback riding. For the rest of the people, when you're not around horses, you don't care. And dust mites, donkeys, but dust mites, this one, they're around all the time. They're around all the time. And so when you have someone that has allergies and they have this stuff all the time, it's basically, it's dust or pets, because that's what's on all the time. And then what's not on there is that occasionally you have people that have pets that they don't know about. Because, you know, certain times of the year, there are these rodents that are outside that like to come into your house. And you can be allergic to them too. And then there are people that, and actually most asthmatics will get cold viruses will actually trigger them. And the viruses, you know, rhinovirus is the general cold virus that everybody gets. Respiratory syncytial virus is RSV, and it also, when you get infected with it, it also affects more the lower airway, or as close to your alveoli. And this is what makes these babies really, really sick. It also affects people who are at the other end of life. It makes them sick. And so you don't want to get that. And then influenza, that seasonal influenza. And seasonal influenza virus can make a normal person's lung behave like an asthmatic for 3 or 4 months. And so if it does that to a normal person, think about what it does to an asthmatic, which is what you don't want to get that. And then when you have all of this, when you're inflamed, smoke, cleaning fluids, air pollution will affect you. And then weather changes will do that. And every time the weather's changing, the barometric pressure is changing. And your body has to adjust to that. And then for normal people, you don't do that. And basically, when I was, one of our program directors actually had this theory that as humans developed, we lost this ability to be able to tell seasonal things, weather changes and all that. Because he said, you know, like when we're getting ready to have a storm, all the birds disappear. And it said, when your tissues get damaged, you actually can tell all of this again. And I think he's right, because when you have this nasal stuff, as long as you're inflamed, you can tell when the weather changes. You can tell when the temperature changes. And it's the same. And like people who have damaged joints, they hurt when the weather changes. And I think that's probably true. You're releasing these sensors that we decided we didn't need.
Question?
Go ahead.
Is there a difference between the dog and the cat? Is it based on maybe long hair, short hair? Is there the dander different between those? What is it? Or is everybody just, is the difference that some people can tolerate dogs better than cat, or don't set their asthma off as much?
In general, cat allergen is worse.
That's what I would
than
say,
dog.
because I have asthma.
In general,
But
it's
cats
worse.
bother me much more than a dog does.
And that's the case for most people. And cat allergen is sticky, and so it sticks to stuff. And the allergen, and actually for all of them, the allergen comes out in the oil glands. And so it's not the hair, it's in the oil glands, and it comes out. There's allergen in the saliva. There is allergen in the urine. And so we have people with cats, you know, they have this, and I've had them where, oh, the litter box is in front of the air intake for their furnace. And it's like every time the heat comes on, they blow allergen all through the house. The other thing that's interesting is that, just like we said, there's no such thing as a non-allergenic dog. We have people that have some breeds that bother them more than others. And I know I'm allergic to dogs, and I'm like that. Some of them don't bother me, and some of them do. And the things that also, it's like, also depends on the age of the animal, because when they get older, you know how we fall apart when we get older, they do that too. More secretions come out in there. And then dogs, male dogs are worse than female dogs because there's an allergen in the prostate that comes out that some people are allergic to. But you know, the real thing is like if you're allergic and you have these pets you're not supposed to have.
But I often hear about idiosyncratic, where you have, you develop allergies that you were able to tolerate it, but for some reason, you become allergic to them eventually.
Sometimes you have been allergic to them all along, and
Okay.
something in you changed that you start having symptoms.
Okay.
No, it was another one of the people that started talking about, okay, you have allergy genes and you have symptom genes.
Okay.
And the reason is that you do have people that if you test them and they have positive skin tests to everything, and it's like they don't have symptoms.
Okay.
And then we do have the thing that I hate the most is non-allergic rhinitis. And the real thing is that the nerves that are in your nose are actually over-responding to all this non-specific stuff. And it's like, and so if it's doing that, it's having because you're supposed to do this anyway, normally, but they're having an over-response. And what happens is that regular antihistamines don't work for that. And so you really need the sedating ones to do it because it's blocking the nerve response. And your body knows when you're blocking the nerve response, and after a while, it will release more mediators to counteract that. And that's why you have people that say, oh, that worked, and it's like, and then it wore off. And it's because your body was doing that. And I had one person years ago that was paid so close attention that they were on 2 different antihistamines, and they know they lasted for 3 weeks, and it's like they would take one for 3 weeks and then switch. Everyone doesn't pay that much attention.
You know, I never had hay fever in my life until I came to the U.S. And then there's a saying that Europeans that come to the U.S. develop hay fever after they've been here 7 years. And in fact, I had hay fever. 3 years, okay. And there's this one plant called ragweed here that we don't have in Europe. So that really set me off.
Well, actually, ragweed grows primarily in the middle part of the country.
Okay.
And so, but it blows.
That's right.
And it blows. And so we also had people, I don't think it blows all across the ocean, but we have people on the East Coast that get sensitized to ragweed. And when they move to the Midwest, they feel like they're gonna die.
Yes, that's what I felt like.
And that can happen, which is why one of the things is like, if you move to another part of the country, you might be fine for a while because you just left where the allergens were, but you can develop an immune response to other stuff. And we do have some of the kids that are in the military that they were lucky enough to stay in the country. Their parents moved all over the country. We have people, they're allergic to everything all over the country.
Wow.
So, all of our asthmatics get what we call a spirometry. This is a simplified version of a pulmonary function test. And one of the things we're looking for is your forced vital capacity. And that's when you take in as deep a breath as you can and you blow out as hard and as fast as you can. And one of the things we measure is how much air comes out in 1 second. And then there's a ratio of how much you took the breath you took in and how much air that came out. And arbitrarily, anything that's between 80 and 120% of the predictions is classified as normal. And your predictions are based on your sex, your height, your age, and possibly your race. And because it's like, our systems are set up that if someone is black, your 80%, everything is decreased by 20%. And that's presuming, and that's on the presumption that your legs are giving you a greater percentage of your height than your upper body. And that's true for some people, and it's not true for some people. Because I know I used to be able to get 140% on spirometry, and I can't do that anymore. I think that is because I got old. But based on that, you have to look at that. But when you're doing these, and when everybody that comes in for a new patient, we'll give them a bronchodilator and repeat their test. And it's also because what is that the numbers that they're getting that you're on there, even though they may look normal, that might not be their normal. They might be better than that. And so you need to do that to see. But generally, you're supposed to be able to get out 80 to 85% of your air in 1 second. But if you were a little kid, you can usually get these tests on 5-year-olds. Some 4-year-olds that can get it. If you have a really cooperative and smart 3-year-old, you can get them on a 3-year-old. Because all of this is, if you're taking a deep breath and blow, and some of our machines have candles on this. Actually, you're going to blow out all the candles, and you can get this. But these younger kids can get out 100% of their air in 1 second.
Wow, that's nice.
And so when you're looking at this, the machine will tell you this stuff is normal. But if you have one of these kids and they're having all these problems, and you're looking and they're getting out 80% of their air in this 1 second, they're obstructed. Even though the machine is telling you no, they have an obstruction. So when you're looking at all of these, you actually have to think about all of this, their age, and all of this. And it also is, they have to be cooperative, and it's like, it's effort dependent. And so sometimes you can't get people to do it.
So
And it's effort dependent. They just.
So anxiety plays into that also?
It could. It could. And so when you're looking at this, and what's interesting is you're teaching this, the little kids catch on to this faster than the adults. But what you're looking at on here is that this line right here is when the air is coming out the fastest. And for people that have done stuff where you use peak flow meters, that's your peak flow. And your FEV1 when you're going through there is, because it's on here, and you'll see how much air came out when you got to the second, but that actually is your volume. And go ahead. Did you?
No, so your peak flow is at very tip top.
Very top.
What's the bottom at? What's the bottom?
Oh, this one?
Yeah.
Okay, this is actually, we call this is a flow volume. And so, you actually, when you do this, you actually have people taking a deep breath. So they start here, they blow all of their air out, and then they take a breath in. And when you're saying that, sometimes when you're looking at people, you can see up here that this is flattened at the top, and it's flattened at the bottom, which means that there's some obstruction up in your trachea that's keeping the air from coming out. If this bottom part is normal and it's kind of flattened at the top, some of the people, when their allergic rhinitis is really bad, all these mediators are dripping down on their vocal cords. And so the cords aren't opening up enough to get the air to come out like it's supposed to. And when you treat that, when they come back, it actually gets better. But there are times when I see them that it's flattened and it's flattened, then I go and get my stethoscope and listen at their trachea, and it's like, and I had one of these kids, actually, I don't know how he got this piece, it was like a straw, small straw, it was in his trachea, and you could hear it whistle as he went through. And the kids do stuff. And one of the things, these are skin tests, and each one of these spots that's on here are these allergens, and people say when we do that, it looks like mosquito bites, and basically, when mosquitoes bite you, they actually cause the mast cells to release histamine. And they also cause inflammation, which is why they last for a few days. And
So why do they like, some people more than others? Why do some people get more mosquito, like, I'm out in the evening in the summer and they always find me.
oh, I love you. They're thinking that sometimes it's the carbon dioxide that people are releasing that's doing that, because that's really true. They like some people much more than others, and
They always get me. So
But isn't
that's
it,
why
when you wear more
can't
colognes and
shorts.
stuff like that, and perfumes, I thought
Oh,
they were
schizo
wrong
stuff.
there.
Yeah, I have to use some mine. I mean, that's
bees are.
Bees.
And I don't know, is that I know from being on the farm, the people that worked outside all the time didn't get mosquito bites that they noticed. And I don't know if the mosquito bites weren't attracted to them or not. But what does happen is, like, if you, over time, you get a lot of bites. The ones that you get typically later in the season aren't as bad as the ones earlier in the season. And you're probably getting some suppressor thing. That's all.
Is there a difference between men and women with these mosquito bites? Because Desmond and I can be in the same areas and he does not get bit at all. And I get all bit up.
They like you. Actually, I have a sister that's like that. And because we were down, I was sitting outside once, and she's just getting bit. And we're not getting anything. So this stuff that's on here is basically the stuff that we test people to. And all of the allergy things when we're testing people are the most common things that people are allergic to in that part of the country. And so we have this first set of things, the various molds that are on there, and then we have tree pollen, grass pollen, weed pollen, ragweed pollen, and we have cat and dog, and dust mites, and sometimes we actually can test people to rabbit and other stuff. Because people come in and ask stuff, and we don't do it routinely, but you can.
I have a question. Should everyone get an allergy test? Would you recommend everyone get an allergy test? Should that be part of our physical exam here to get an allergy?
Okay, you really should have that if you really are having problems from this stuff, because it'll help you to control that. When you're saying that, it's like, okay, the money side of us says, so everybody needs this. Everybody needs this, but in reality, no. No.
Okay.
What do you think about the blood test? The allergy blood test
So, skin test actually is better. But, and the reason for that is that you are testing for this IgE that's actually bound to the cells. It happens with the ones in your skin, but it's bound to the cells that are out there that's actually going to give you a problem. And so sometimes in your blood test, all the antibodies outside the bloodstream, and so because it's out there doing its work, and so you'll do this and you'll get negative tests. The other thing is that you have two types of IgE, and you have one type of IgE that actually binds to the receptors tighter than the other ones, and that's the one that's actually causing the problems. But it's the same IgE that's circulating out there, and so if you just do that, you may say, oh, you've got all these positive tests, you can't do this, this, and this. And that's not necessarily the case, because we're doing these tests to confirm our history and not using your blood test to make your diagnosis. And it's like that's how you do everything else.
So we're talking about mainly like naturally occurring environmental stuff that causes allergy. But what about stuff like medication like penicillin? I mean, how does that do?
That's more intense test. And technically, penicillin is the only antibiotic there's actually tests for. Because of how I got trained, it's like, can you make an IV solution? If you can make an IV solution, you can dilute it down, you can test to it. And I have tested to cephalosporins and And anything, it's like anything, it's like you can dilute it down. And basically what you do, because when you do these testing, you start out with very dilute and make a scratch, and then even dilute it more if it's negative to actually inject it into the skin. And for these other things, you do the same thing. It's an IgE response. But one of these, because these people have had anaphylaxis, you want to start with a low dose and just get a response on their skin without making them sick.
But you know, like my question too is like sometimes people go to the doctor. Most common question is, are you allergic to penicillin?
Yeah, come get us and get tested so we can tell you.
So is there any way that a person can tell if they have a true allergy versus just something they have sick or
No, we ask questions. We actually ask questions and start asking what happened to you. Because just making you sick, because stuff can make you sick. And if you think about it this way, your stomach is there to eat food. Not to take all these medicines and all this other stuff. And sometimes this stuff will make you sick. And like the class of antibiotics, the erythromycin, makes you sick. It causes your stomach upset. And it's like, that's not an allergy.
One other question that still relates to antibiotics, but I don't know if it's the same thing. Like Bobby Caldwell was recently passed, and they were saying he had a long-term relationship.
Oh, ciprofloxacin, you know, he was fly, what did they say, fly? He had that,
Is that-
neurologic, I'm not sure exactly
It's the
which
quinolone.
one he had, but it was the fluoroquinolone.
Yeah, that's the quinolone. Is it a quinolone? I'm allergic to the quinolones. I mean, I had the rash, the breathing, and hallucinations and things that
Most people, because we have people,
Those
I
are
tested
quinolone,
this
the
too,
ciprofloxacin.
and it's like they're allergic to it. But most of them is what we call adverse reactions.
Yes.
And that's the thing, it's like it's adverse, it's like it's doing that, and lots of stuff can do that.
Because you know, with the fluoroquinolones, they can have the tendon ruptures, and it affects their collagen and all that, and they can have uric aneurysm, and so that's what that's how we have. But that's the type of reaction I think he said it's supposed to
Yeah.
have. But that's not an allergy.
Okay.
So it's an adverse reaction.
Okay.
So the allergy is where like
It's IgE, it's IgE. It's an IgE response, and we do, and actually how you have to write letters, because you don't, you just won't say they're not allergic or something like that for these medicines. It's like they did not have a reaction consistent with an IgE reaction.
And the only reason I'm bringing it up is people will hear like the feeling of like, oh, I get an allergic reaction, but it's a little more complicated.
It's an adverse reaction.
Yeah, and when people have that,
That's what
we always
people
ask
can't
them that.
take.
It's like, what happened? What happened? Because you want to know what happened. And a lot of times, people are allergic to penicillin. They say that because of the reaction that they had when they were babies and they had some virus infection and they got amoxicillin and they had a rash, and usually it's the virus that they had that caused the rash.
Okay.
The other thing, people come in, they say, well, my mom is allergic, or my brother's allergic to penicillin, that means I'm allergic to penicillin.
Yeah, I know, and it doesn't work. That one doesn't work that way. That one doesn't work that way.
But no known allergy.
Pretty much what Keith was talking about, I've gone to different things and when he's giving me antibiotics, you think of that, I'm allergic. This is since I was a child, I'm allergic to penicillin, streptomycin, and all sorts of drugs. I don't know if I still am or not, because I never want to try it, find out if I am or not. So,
Okay, technically, like sulfur drugs, that reaction that people get is not. They're giving me grief over here. You don't even see it. It came out.
I didn't hear what you said.
No, I was teasing. It's like they're giving me grief because I'm not looking at them over here. I'm just teasing. The reaction that people really get from these sulfur drugs is where they're not metabolizing it though. They don't metabolize it. And these toxic particles from there actually damage their skin, which is causing that. And that's why they get, it's like burns and things that they get. That's an actual reaction. Because most of them don't have allergies. It's not allergies, it's a different reaction. Basically, it's an adverse reaction. And sometimes it also is that it's what you're sick with, again, that's you have, when you make an immune response, you make these IgG antibodies. When they bind to things, it also is another set of proteins that are called complement. And these IgG have receptors on it for complement, and when they're on there, complement will come and get on there with it. And it eventually, it's a whole pathway that goes to, and eventually you get what they call an attack complex. And this molecule actually, it's like this bacteria, goes in there and releases, it actually kills them. It actually kills the poison cell and kills them. But one of the compounds, as you're going through there, like complement C3 and complement C5 break down, and they're components of C3A and C5A, also cause histamine release. And so if you're releasing histamine, you can get rashes from that because of the immune response that you're doing. And if you think you get histamine, remember, histamine makes your blood vessels leaky. So it does that, your blood vessels, so more stuff can get to places.
So my question, I don't even know if I am really.
You need to come see us and get tested.
That's right.
Something that's, you need to, that's one, when they keep advertising, it's like, because if you say you have penicillin allergy and you're in the hospital, they're going to give you something else. And sometimes penicillin is the best medicine for that, even though they will give you something that's going to work. And giving you some of these more broad spectrum antibiotics can lead to more complications.
Right.
And there are people that are in the hospital longer because they can't take penicillin. And so that's the reason why you need to have that.
Also, I think the tear. Now, I just heard you talking about animals. I have a dog. I've had animals like most all my life, but I have come there tear like all my life. It just made me think. I wonder is because of the dog that I'm actually tearing all the time. And they gave me something in the drops in here. Still looking at like literally talking to someone and all of a sudden, oh, did I say something I can feel it or something? No, I'm just kidding. Sorry.
That might be, but as you age, you dry out. Your tear film changes. It's not, so it doesn't lubricate like it's supposed to. And because of that, you will tear. You'll actually make, your tears are more watery and you'll make more of them. And when you dry out, you don't have the natural protective mucus layer that you're supposed to have. And so these allergens bother you more also.
So it could just be old age.
I can say that.
Okay. Okay.
I also have sometimes with patients and they're saying, and I've never had this, they're saying, you've never been this age before.
Right.
Okay.
So is the question he's having is about tearing? Is that-
Yeah, he's just having tear.
Just use just use the eye tear, the artificial tears, because you do tear more when your eyes are dry. You think it's the opposite effect, but it actually isn't. You just tear more when your eyes are dry. If you're on the computer more, different various things cause it.
Yes.
Also the changes in weather, all of
Yes.
those things. Just use the artificial tears over the counter. And you just use them several times a day, maybe morning, noon, and night. That'll help control all that extra tearing.
Okay.
And that's an easy thing. About the being in the hospital when you're allergic to the medication, if you need that antibiotic, and that's the best antibiotic for you, they will do the testing to try to see if you actually are allergic to the antibiotic, if they really need to use that. But the spectrum of medicine and antibiotics has gone so much further nowadays, they'll just usually avoid it. And one of the things why they do is they don't really know, if you can't describe what reaction you had and you were just told that, no one wants to give you that antibiotic and find out you really had a serious reaction,
Right.
or potentially could have a second, because of mounting, re-exposed to it, you could have it. So it is not a real issue because there's so many antibiotics out there now, we get around it. So you're allergic, you say you're allergic to what, they're just gonna use another class.
And really, and for
That's
most of
what I'm doing to keep, dentistry.
Are you gonna put me on, right?
Yeah, if you're not finished, the dentist will give him a hard time. Well, he knows you know.
You hear my name.
Yeah.
But I'll tell him that.
He can say that. He can say
I know,
that.
man.
You can't.
I have a question.
See how bogus that is?
Yeah, that's what I did.
So what currently is the cross-reactivity effect between the cephalosporins and the penicillins? They used to be, and I don't know, is it still there, or do we avoid it, or?
The
where is
first
that?
generations have been the ones that are closer. The second and third generations, most people can take.
Okay, they've been clear. Thanks.
And so basically, don't give, if they're, that don't give them Catholics, give them us.
Right. So the question I was asking is about, sometimes we used to have people who had allergies to penicillin. There's another class called cephalosporins. Those are used a lot for a lot of minor infections, which is Keflex. I don't know. I mean, that's a common trade name you hear on the medicine. They used to have a cross reaction. So we used to, if you were allergic to penicillin, we did not give you that Keflex because there of a possibility. And I asked him, what is that? Where is that at now? But once again, like he said, we're now into second and third generation cephalosporins now on some of these antibiotics now. So he's saying that the first generation gave you the most cross reaction. We can go over that and give you the second or third. Or sometimes we just give you another medication, another antibiotic now, and we don't have to even worry about that cross reaction. And that's where you get into the different classes, and that's, we have so many of them out now. It's even hard for us to keep up with them anymore. But they just constantly go around even trying to give you something. If you say you're allergic to A, B, and C, that's all right. We got 4 more classes we can use on you that'll work.
And I am going to try to get tested because, Dr. Denise just said it didn't make me something where penicillin is the only thing that will help me.
Well, but if it is the only thing that would help you, you would
That's,
be.
I was just giving an example. I said, wonder, if there was a disease, and that's the only thing that would
Yeah.
help.
But if
Which is not likely.
Yeah, but if you do, they will test you. They still do testing in the hospital for it and make sure you get around it. If that is the only thing they'll do the testing. And they'll see if the testing shows that you can take it safely, because we're really looking for you to have a really anaphylaxis, serious allergic reaction to the medicine, not a mild one. So a serious reaction is the issue, and not an adverse reaction necessarily, but a serious allergic reaction. That's what he's been talking about all day. Is the difference between an adverse and a serious. I have a skin rash that I have when I took a medicine that has a sulfur-containing thing. So when they ask me, I will tell them I have that. That's not necessarily a serious reaction. If I needed a sulfur medication, they could give it to me. They would have to watch me, but they could give it to me. Your serious reactions are the ones where you drop your blood pressure and where you think that you're gonna die. Your tongue swelling, facial swelling, all those are serious reactions that they don't want to give you medicines for.
And that's anaphylaxis.
That's the anaphylaxis he's talking about.
Yeah.
When you drop your blood pressure, go into shock-like state, your tongue swells, you can't breathe, you get tight in your throat. Those are things we don't want to see you have with these medicines. And that's where we decide, no, we can't give you that. We'll go around and give you another medicine.
So when you actually have someone that's really had anaphylaxis, they are in the hospital. You need penicillin, we can still give it to you. And you do, as you said, you can actually desensitize. And what you do, because remember I said you have to have, the IG has to bind, 2 of them have to bind to the same thing at the same time. Well, when you desensitize, you start out with a low dose of penicillin, and you just gradually increase it. You bind up all the receptors. And they can't cross-link, so you can't have a reaction. But when you do this, for treatment, your antibiotic has to be on time. Because, sometimes, you're late and all of that. And if you're late, you can start unbinding the sites and you'll have a reaction. But you can do that, so you can get that.
But you wouldn't necessarily walk back into a doctor's office and say, oh yeah, I took this in a hospital when they did that, because we're not going to be able to in an outpatient office, desensitize you. That has to be done in a hospital setting.
And so there are some antibiotics that are not friendly to women, And those are the minor things that you're talking about, that sometimes women take like Careflex or other things.
I don't know if it's how much women or men are, I don't know.
I'm just talking about particularly, there's an antibiotic that will cause yeast infection in women.
Yeah, well.
But I'm just saying, because it wipes out all the normal flora, but
We can
it's
do
still
that later.
good for
We can get
them.
back on topic.
Okay.
Y'all elevate, y'all going down low.
But we're women, you know,
We up
okay.
here.
It's because we're women, you know, but
Y'all-
medicine is not
Y'all
always.
keep taking.
One of the things is that you have environmental control, because in reality, the treatment of allergy is avoidance. And it's just like, you're allergic to penicillin, you don't take penicillin. And so, you want to avoid this stuff. However, when the stuff is outside, you can't always do it. And this is the plants, and actually, you have a handout that actually has these on there. But this is tree pollen. You see that tree pollen is from March to early May, which means that this is a long season. And maple trees start pollinating at the end of February.
Yes.
And it is because the days, actually technically, it is because the nights have become shorter is what start triggering these pollen seasons. And people say, oh, it's warm and all that. It's like they start at the same time because of the length of day. That's what it is. When it is warm, well, they'll metabolize faster and they might release more pollen faster. And because you know, every year you're gonna hear why, oh, this is gonna be a bad allergy year.
Yeah.
It's always a bad allergy year. And people have different reasons why it's gonna be bad this year. But one of the things for trees of how they grow, the growing season the previous year affects the pollen season for the next year. So when we have these years that we had droughts for these trees, they have been stressed. And so it ends up, they actually won't put out as much pollen the next year because they've been stressed. And our trees are supposed to, we're in winter, and they lose their leaves, and they don't go completely dormant, but you know, they evolved to be able to live in winter. And so, for most of our winters, it's okay. When we've had you know, these winters where it's really, really, really cold, that does stress them, and so they won't be quite as healthy in the spring as that. But it's like they're supposed to go through winter. And with, you know, I was thinking about interesting because of climate change and stuff is getting warmer. Don't know how that's actually going to affect them. And because all of this does, and if you think about it, the reason why they lose their leaves, the deciduous trees lose their leaves, is because the days have become shorter and there's not enough sunlight and they can't do photosynthesis, and so they lose their chlorophyll, and that's why they drop their leaves. And when they lose chlorophyll, they go from greens with all the other colors that are in the leaves anyway. But that's how they're supposed to cycle. And you know, basically we have 6 months of leaves and 6 months of no leaves. It's really, that's about what we have. But you see, this is like from allergy through May. Okay, this is one that these are the leaves of an oak tree. And if you start looking at plants, you know, if you look at their leaves, you can tell which plants are related to one another. This is the pollen. This is tree pollen. And the tree pollens actually look like this. It's a triangular in shape. And people tend to complain about eye symptoms from tree pollen more than the other pollens. And it's probably because of that shape, because it's irritating. And this is just another tree. I think that's an elm tree. And these are two different species of maple tree. And this is the silver maple, and this is the one that I think they call box elder. And if you the leaves, they look real similar, even though they're slightly different. And so, where you had trees went from March, through May, well, grasses start in the latter part of May, go through June, May, go through June. So you'll in one season start another season.
Wow.
And the grasses that cause the problem are the wild grasses, the ones that are on the highways and vacant lots and all of that. And it's not the grasses in your yard, because most people don't let their grass grow long enough to go to seed, because they don't like the way it looks, and your neighbors will not like the way it looks.
Except for those neighbors who don't like it.
So, but when you have this, and so this is where this part of the plant is where the pollen comes from, and this pollen blows, and so you'll have this where people will come up and they say, "Oh, I'm a tree pollen, I'm gonna cut down all my trees." Well, depending on how sustained winds have been, we have pollen that comes here. It comes here from Iowa, and we also have grasses, because we have people that would test to if they're positive to Bermuda grass. Bermuda grass grows in the southern part of the country. And we've had some people, they have never been down there, but the pollen can blow up here. And I'm wondering, because I'm looking at the weather, about how this weather with this winds are coming up from the south, and think, what are you blowing up here? And these are grass pollens on this side. And these are they're weed pollens on the other side. And they actually, because ragweed pollen, because you look at it, it's like the spikes and stuff on there. Ragweed has more of them on there than the grass pollen does. And then we have the weed season, and basically from June through October, there is some weed that's pollinating all through the summer. And most of these other weeds tend not to cause people that much problem. It is ragweed that it is really bad. And one of the things, it's like, it might just be really bad, but if you have someone that also has tree pollen allergy, and then you have grass pollen allergy and some of these weeds, because of the reaction that you get, your nasal mucosa is all inflamed. And so, and once you start having reactions from one allergen, it makes it easier to have it to the other ones. And it's really possible that you've just gone through all, and it's just like, that's just one more thing added to that. And in addition to that, mold is outside from when it thaws out in the spring until it freezes again. And unless you have a winter like this, that it never really froze long enough. But they like humidity. And so as you go through the summer, the mold counts gradually increase, because if we have a nice humid weather, it's just more of it out there. So you have more of that. And then the dust mites that are in your house. Dust mites like warm, humid weather. And so here, as we get into August and September, your dust mite population has increased. And so at that time of the year, you have more dust mite allergy, you have more mold, and you have the pollens. And then if you're unlucky enough to have some of these other pollens that bother you, and so then you end up like me, you get on allergy shots. And yeah, that's ragweed. And then these are some of the commonest molds that are out there. And what you're allergic to with the mold are the spores. And the spores are how they multiply. And so they just blow out and go everywhere. And so when you have places where people sit there in their damp basement, the basement smells damp, you're smelling the mold. And it's like, and it's enough that you can smell, but it's not necessarily enough that you can see. And if you've had floods or anything, all this stuff, it's like mold gets in there and it grows, and you really need to get rid of it. This is magnified a lot, but that's mine. The dust mites live in your carpeting, they live in your bedding, and they especially like concrete that's on a cement floor, because that creates a vapor barrier for them, and they like to live there. And so there's some times when you had these lower level family rooms, and they had people that say, you know, every time their kid goes and plays on the floor in the family room, they get sick. And sometimes it's that. I had one that they said that they kept having a problem. They kept having a problem when they would go into their family room. Until one of the times we had this heavy rain, and water wasn't seeping in. There was an actual crack in the foundation, and water had been seeping in, and it was actually mold there. And there are two species of dust mites that we're allergic to, primarily, and it's like, well, we actually call them DP and DF. And the DP, the pterodactyls, actually thrives better in more humid weather, and so that's where it's more of that. The D forini are everywhere. And the same thing is that occasionally we have people, we test them, and it's like, you're allergic to DP and not the other one, and it's like, why that one? Because it's everywhere. And years ago, when he's actually was studying, they were trying to figure out what was in house dust that was really bothering people, and they actually were looking for this, and they figured out, and it's like, and it's actually not the dust mite, it's actually the dust mite feces. And when we give people under environmental control, we've had pamphlets that had pictures of your dust mite, and sometimes I laugh and say, I know it's that picture that makes you do your environmental control, and not anything that they read. Because it's like when you think about it, that's there. And there's stuff that you can buy covers for your pillows and covers for the mattresses, and they have, because any of the plastic covers will work if it seals it. But you can buy more expensive ones that they have done stuff to the fabric so it feels more like cloth than plastic. So you don't feel like you're sleeping on cloth, on plastic. And you can get them for your pillows. And really, if you're washing your sheets, your water is supposed to be at least 128 degrees to kill it. No. That won't kill it.
What about dryer? That won't kill.
What about hanging them out in the sun?
Right.
Dryer heat.
I don't know if they studied that, but they would tell me how hot the water is. Because the next thing really should say pharmaceuticals. That went back. That was actually a slide on the mold control. Basically, you want to decrease your humidity, and you really want your house, the humidity in the house to be between 30 and 40%, because if you get more than 40%, it promotes mold growth, and if it's less than that, you get too dry. And these are just the common animals, because it's like if you saw the first animal I put up there was dust mites. And these are the others. And one of the things that we have, that people have these animals, and the treatment you know, it's like you're supposed to get rid of your animals. And it is real easy to say, get rid of your pet. It is real hard to get people to do that. There are people who have dogs that will get rid of their dog. Most of them find a relative with the dog that they take the dog to. People with cats don't ever get rid of their cats. And I don't know why they want these rodents in their house, but they do that. But one of the things that sometimes people have, they come up and say, can I try a pet? And I look at them and say, so you're going to tell me you're going to get this pet, bring it into your house, and sometimes just a few weeks before the symptoms get really bad, and then you're going to get rid of it. And I just look at them and it's like, that is not fair. This is me of where I have fish. My fish are outside. And that's not fair. That's not fair to the pet. That's not fair to any of the people in the house. And I know, because they don't think of it that way, but when I make them think of it that way, I know they're either going to get a pet or they're not. And for people with horses, sometimes it's like when they really are riders, it becomes a problem. And one of the things is like, we eventually we can get shots for that too. And one of the other, I just put it under the other insect animal that we had, it's called cockroaches. They actually, their body parts become part of the dust. And then we have people that are, that was in the dust. And then they have people who are allergic to, they look at this, I've never been around cockroaches. And I kind of look at them and it's like, you just don't want to know where they are. They go where the food is. They might need the batteries. So out of these, the best therapy for this are inhaled steroids. And because you actually, for any asthmatic, you could give them like 20 milligrams of prednisone every day. They won't have a symptom ever. But they will have thin skin, they'll have calcium that won't go into their bones. After a while, they get cataracts. If they're so genetically predisposed, they have diabetes. And the same thing with thin skin. You have thin capillaries because you see people that have bruising because what steroids do, what the natural steroid is supposed to do is protect you and to help you get ready for stress. And so it will increase your blood sugar and it will do this for a stressful situation. And it will stop protein synthesis for everything else except for that. But it's for a short period of time. When you're taking this stuff every day, it stops protein synthesis all over the place, except for raising your blood sugar and storing energy. And because you need energy, it increases your appetite, so you can get more calories. So, but that's really, and then one of the people who I trained under wrote one of the textbooks. That he used to do this stuff. He'd come in and they said, what's asthma? And we'd give him these long definitions and stuff. He'd look at us and say, no. And eventually he figured out he wanted us to say, I don't know. And really, the next thing we're talking about is allergic rhinitis. That's the disease we're calling allergic rhinitis, and the symptoms you get are all this other stuff. Well, this other stuff we're talking about is asthma. That's the symptom you get from all of this other stuff. Because we don't know what this is. We really don't know what it is. And we just can treat it better. But basically, the inhaled steroids are, and the first ones were, they used to have Decadron in inhalers, which is an older steroid. It was very potent. And when you used it in an inhaler, you got steroid side effects, just like you did if you take a prednisone. And so as they develop these other inhaled steroids, it's like, so you take them and you don't have the same side effect from them in the doses that you're taking. But Flovent, which which is, it's actually relatively potent. For the people who are on the highest dose of this, which are the sickest people, some of them do get steroid side effects because of how much you're giving them. When you're getting these lower doses, you won't. And basically, Flovin, which it now has a generic, we think, because the pharmacies want us to write this, but every time we do, it says it's not covered, so we don't know. But it's fluticasone propionate, and basically it's it comes in 3 different strengths, and I actually have on the slide. We have this discus strength and this in the inhaler, and so the inhaler is 44, 110, and 220, and the discus is actually 50, 100, and 250. And for the combination, there's a higher dose of the discus for the combination, and basically the dose we take when we're starting somebody depends on how sick we think they are. And there are guidelines that you have about when they're at this stage, and if you want to get people better, you really need to treat them at a higher stage to get them cleared up, and then eventually step down your therapy. And stepping down your therapy takes slower than you think, because as soon as your symptoms are clear, you can't step down therapy. You have to continue that for a few months. In some people, it's a few years. And so, the company that makes Flovin, GlaxoSmithKline. So Flovin came on the market in the middle 90s. And because, this stuff got old, they wanted a new product. And so they have one that they call Arnuity. And it's still fluticasone. They put another, a fumarate molecule on it that made it a little bit more potent, and it would stick to the membranes better, so it would work better. The difference is that the old ones you took twice a day, this one you took once a day. And when this came out, and we were telling people, oh, okay, it's up once a day, and they said, oh, only once a day, and you're looking at them and say, you're not taking your medicine like you're supposed to. But when you have these, your controllers, you need these all the time. And so when it goes back to, when I'm asking all these questions and you're on this dose of steroid, it's like, if all of a sudden, you need more albuterol, and you're getting shorter breath with exercise and you're coughing, that just might mean you need a bigger dose of steroid. Some people in their pollen season need to have a higher dose of steroid to get through the season, and then go back to their regular dose. And then, the Annuity just has 3 doses. It's 50, 100, and 200. Hold this. And this is, on the other one's Pulmicort, and they now, it actually came in a nebulizer solution. Its nebulizer is actually also generic. And Q-Bar, which is beclomethasone, and this is the same medicine that, if you remember Vanseril, it was a pink inhaler, and Beclovin. Beclovin was from Glaxo. Vanseril was from Sherry. It's the same medicine, but when they changed the propellant that was in the medicines, where the old MDI said basically the propellant was Freon, and the same Freon that was damaging the ozone layer. Yeah, it was Freon. It was in there, and yeah, you can have adverse reaction from taking too many inhalers too from the Freon. But when they changed, they now have the propellant that's in there. It's hydrofluoroalkane, so it's HFA. And so when they did this, they changed the name. This company came out with Q-Bar. It's a different company, and this is one that I remember the reps coming in with this, and they're talking about this. They said we have this brand new medicine, and you kind of look at them. It's the same stuff we've been using. One of the things that happened with this, the HFA propellant, the medicine's dissolved in it better, so it came out as a solution, and it actually got into your lungs better than the previous propellant. And so sometimes you can use a lower dose of this stuff because of that. The Pulmicort is actually a dry powder inhaler, and what they did, it's actually the brand name is Pulmicort Flexator. The original Pulmicort was called Perturbator. And around the time that their patent was running out, they changed the concentration, a little bit of the dose that was in there. It changed the device that you're using, so they had the patent. They do stuff like that. And then we have these, we call these anti-leukotrienes. And this is just because there's this compound that comes out of your cells. It's a fatty acid called procarbonic acid. It comes out of the cell membrane. And I actually put this on here because there's two pathways that we call, it's like oxygenase pathway, which is where you get leukotrienes. This same pathway is actually where you get another set of compounds that are called prostaglandins that do something. And there are some people that are sensitive to these class of medicines. And when you take them, if you take these, you will get wheezing. And it's because when you block it sends it over to the other pathway, and some people get symptoms. And leukotrienes are that you have, and one of the medicines that we have that they block the receptor for this, and it's montelukast and zafirlukast that we have, and basically it's singular and accolade. And when these were coming out, they were studying, and there was more and more and more of these that we were going to be having, because it looked like in theory, if you block that receptor, all your symptoms would go away, and that just didn't happen. And the Xyluten, which actually came out before the other ones, almost no one ever uses. It works. It's an enzyme inhibitor, and so it should work better than the other ones, but it worked basically the same as all the other ones. And when you would do this, you would have to do blood tests on these people every month, and multiple times, because it caused liver enzyme elevations and other stuff. And so after a while, you had basically Singulair that had no side effects. That's what we started using, because you didn't have to do blood tests, you didn't have to do that. The other one, the accolade that was on there, you had to take it on an empty stomach, and after a while, you just gave that. And it came out the less, but that's the one Merck made a whole bunch of money on. And then you have what we call these quick relievers, which are the albuterol. And those are just the brand names that you have. And the lead albuterol, that is, it's just the active component that's in albuterol. And we have some people that are on that because albuterol makes them so shaky.
What is primatine mist?
Epinephrine.
It's what?
Epinephrine.
Epinephrine.
Okay, all the same thing. When they said they modified the steroids, epinephrine works within 2 minutes of taking it. It makes you shaky, it makes your heart race, and it lasts 20 minutes. And so all of these molecules.
Is that why that's over the counter and? Oh no, that's on the shelf, right?
No, it's over the counter. Yeah, the medicine that's
Wait,
over the counter.
over? Oh.
It's over the counter. The medicine that's
That means that it's on the shelf.
Yeah.
It's over the counter.
You can just, this medicine that has much more side effects and is much more dangerous to take is over the counter. And some of that is because it's old. It was off the market. It actually was off the market. And one of the things, though, there's nothing wrong with taking that in. A couple of times a year, you need to do something. It works. And if that's all you need, there's really nothing wrong with doing that. The problem is that you have people that have bad asthma, and they're taking it all the time. And this medicine also has a problem. It has what we call tachyphylaxis, so that if you keep using it, it quits working.
Yeah.
And so this one, this is a brand new. It got approved in January. It's a as needed medicine. It has albuterol in it and a steroid. And noticing that, these people get better faster when you do that. And I presume other people notice that too, which is why we have this one now. But for the combination, what we're gonna have next slide, the combination ones are, they have these long-acting bronchodilators in them, and one of them works immediately when you use it. And when you do that, it actually, it's called, the Symbicort actually has an approval in Canada to be used as needed. And, which is fine if you don't need something all the time. But if you have somebody on that all the time, because I was in one of these conferences and they said, oh, you can take more of this bronchodilator, it's not too much. And it's like, they use too much. And they can take 4 extra doses of this bronchodilator that's gonna last 12 hours.
So what's the indication and what group of population you give it?
Which one?
Air spirit.
I think this would probably be someone that is what we call a mild intermittent asthmatic. And so that if they have an episode, they'll get a little bit of albuterol, they're going to get a little bit of steroid, and that's going to get them out of it probably faster. Just like albuterol. But again, it should be, if you're using this 4 times a day, every single day, you need to be on something else. And I have to fill out the stuff to get samples of those too. And it's just that these are long-acting bronchodilators that some evolve from out of Alonzo. And these things actually are bronchodilators, but you are never supposed to use them by themselves. They're always supposed to use them. And salmeterol lasts 12 hours, formoterol lasts for 12 hours, benadryl lasts for 24 hours.
So I have a question. Exercise-induced asthma is an allergic reaction? What if it's seasonal?
It's still a trigger, but when you're seasonal, your pollens are causing you to have these asthma symptoms that get worse when you exercise.
My pollen.
The pollens.
Oh, pollens.
The pollens.
Pollens.
The pollens. And so that, like this new inhaler that Don was saying, what is it good for? That's probably somebody like that. It would be good for that if you're using albuterol before you exercise.
That's what I do. I still get I still get.
See, when you're still getting it, that means you need to be on something else, because that really means you're having something all the time, and then when you're triggering it, just pushes you more. And we have people that say they're fine, and when
But right now I don't have any of it. I don't need it. I don't. But it's just seasonal.
you should have breathing tests and see, because you might not be normal. Because we have people that aren't normal, and they do that, and we get sent the medicine, and they come back
I
and
just went
say,
through a bunch of tests. They were trying to weed out what is that one thing that you get? Oh gosh, I can't think of the name of it. I can't think. But they were trying to weed it out. And I went through stress tests. I did the other.
you're doing cardiac stuff.
Yeah, they were doing cardiac stuff. Yeah, so it's a cardiac thing that they were trying to weed out. What's the name of that?
Yeah.
You say the test
No, what they were trying to weed out.
They say people got cardiovascular disease.
Well, they were trying to see that, but there was also another.
Good insurance.
Yeah, right.
And so, these are the different combinations, and all of these ought to work for most of the people. And we pick various things, sometimes it's insurance, and since we have stuff you take once a day, twice a day, and it's like, you kind of look at all of that, and you have dry powder and inhalers, and you try and tailor what's going to work the best for that patient.
Anything about the combinations or not?
I would say, what we pick is basically, when you have someone on a single agent and they're not controlled, sometimes adding the bronchodilator will give them better control than doubling the dose of steroid. And which one we pick, sometimes it depends. Like if you're on full head, we might give you Adder, just so you keep them on the same steroid. But that's how we pick those. And these are just different brands. If you're on Pulmicort, I would like to give you Symbicort to keep you on the same stuff. And the Delerva is, because one of the other ones on there was Asthmanex, and it's just the combination. But Symbicort is the one that the Formoterol works right away, and that's the one that they do a PRN in Canada. And that's really, again, that's fine if you don't have to do that all the time. And so, because you get a bronchodilator, it's gonna last for 12 hours, and you do that. But, and it's always picking these, and now it's like you go through and say, what's covered?
That's exactly right.
And we had one yesterday that I picked, I gave them Brio, and the insurance company said it's not covered. And when I looked at it, they sent it through for the generic's not covered.
Oh, they want.
You know, that's funny because I have Brio, and they were saying that it wouldn't be covered by the brand that it was generic, but the pharmacy never switches to generic when it's still on brand.
Okay, so, but the brand is always higher, isn't it?
Well, I mean, it depends on, I don't know how they price
It's
it
a
out and the
generic, yeah.
price point.
Okay.
So, but,
They make contracts to cover stuff.
right.
Okay.
So it just depends on.
No, this is, because basically, this is your head stuff. And again, it's seasonal, same seasons like for asthma. And then the perennial things are dust and pets and, you know, the stuff that's inside. And one of the things, you know, because basically when we're doing these asthma, we ask for all of this at the same time. And what they get, for this, people have sneezing, and when you have sneezing, it's not one sneeze. It's like, it's 5, 6, 7, 8 in a row. And it starts, if you have one, it's gonna continue. And your nose itches, and the back of the throat itches, your eyes itch, your ears will itch. You get nasal congestion, and when you're having a runny nose, it's clear. And so this is sometimes you see these little kids who have this, and it's just this clear stuff running. And there's a family history. And again, when you're doing, asking the environment about radiators, pets, and smokers, if the pets go in the bedroom, and you don't want them in the bedroom. And for outside allergens, all you have to do is close your window.
Mm-hmm. Yes.
You need your air conditioner because it's hot.
I don't know about the books.
But all you have to do is close the window. And for kids that are outside all the time and they're playing outside, this pollen is in their hair and all that. So they really, ideally, you come in, change your clothes, you wash your hair before you go to bed, because otherwise you put this stuff on your pillow and you breathe this stuff all night. And these pollens that come out tend to be worse at night. And so you need to sleep with your windows closed, which is very hard when you get to August when ragweed pollen is out, because it gets cool at night. And people are sick of air conditioning and they want to open their windows. And I do that. And I know better because I get sick of air conditioning. And there have been sometimes I wake up and my eyes are all congested and all of this because you slept with your windows open. And this is just, a picture of a kid. And if you look, they're sitting here with their mouth open.